So next we're going to move on to Elaine Clark, and she's going to talk about some case studies on VTE and ambulatory care. Elaine is an advanced nurse practitioner in unscheduled care at Cross House Hospital, which is in NHS Ayrshire and Arran. She's been an ANP for around 18 years, and she's been involved in quality improvement work, particularly about flow, process efficiency in acute medicine and same-day emergency care. And she's published widely in this area, and she's on the Council for the Society of Acute Medicine as an advanced clinical practitioner representative, and she's done lots of QI projects. So Elaine, we're looking forward to your talk. Thank you very much.
Good morning, and thank you so much to Thrombosis UK for inviting me to speak this morning. Also to our chairs, they put together an excellent programme for this morning. So I was asked to kind of look from the Scottish perspective at a few case studies, and I think in these conferences people kind of enjoy talking about specific cases or interesting cases or common cases that crop up, because this is our day-to-day work. So from the Scottish perspective, I've got a few cases that I'm going to share with you this morning. Please do keep the questions or comments coming, because I think, you know, what we lose a lot in these Zoom conferences is that in-person, face-to-face, chatting things through. So if you've got anything you want to add, share, comments, questions, please do put them in the Q&A section and we will answer them at the end. Right, let me see if I can share this screen with you. Perfect. Can you all see that? I hope you can. Okay, so even the terminology, same-day emergency care, or some units are calling it ambulatory care, even the terminology just now, there's some debate over what we actually call these units. Same-day emergency care is my preferred terminology, but that actually assumes that you deliver everything on the same day. And as we all know, in acute medicine at the minute, you know, 3 to 4 days is the normal bed wait time just now. So are we really delivering things in the same day? There's also an argument not to call it ambulatory care, because that assumes you have to be ambulant and mobile. And of course, anyone who works in these units know you don't have to be. So I'm using same-day emergency care as a terminology, but really you can call it whatever you want. And most of you should, sorry, I'm just trying to get my next slide on. And most of you should have heard of same-day emergency care or ambulatory care, because it's extremely high on all the devolved nations' agendas in terms of the COVID response. Our own Scottish government have said, and this is a quote, that the need for acute care service redesign has never been as crucial as it is today. And so most hospitals, acute hospitals, if you don't already, you will start to develop these same-day emergency care units. What they do is they give urgent care to patients without the need for admission. We can treat a whole directory of conditions actually, but VTE plays a very big role in what we do in same-day emergency care. We give rapid assessment, we give rapid diagnostic tests, and we give rapid treatment. But the most important thing in these units, patient selection is key, because you can provide all these things, but if you haven't got the correct patient in there, then all the things that you can do within that day tends to change, and it kind of clogs your system up a little bit. So patient selection for these units truly is key. But we're looking at VTE. Now, UK-wide, about 9 to 10% of referrals to acute medicine with the presenting complaint of swollen legs will have a confirmed DVT. So that's roughly 1 in 10 patients. So that's actually quite a lot of patients who don't have a DVT but have the presenting complaint of swollen legs. It's one of the most common referrals to acute medicine. I think people tend to think that chest pain or COPD, but actually investigation for VTE is one of the most common referrals to acute medicine. Within my own hospital, we audited patients over a 1-year period in 2019 to 2020. So it was about 4,800 referrals, but the DVT pickup rate was only 9%. So that's over 4,000 patients that needed an alternative diagnosis. And the other thing that you've got to think about with your VTE service is, are you exclusion service? So are you a service that just says, okay, you don't have a DVT, go home or go back to primary care? We decided against that, because actually what we found is that patients would just constantly represent, because there was a reason out there why they had a swollen leg or swollen legs. And us just saying, okay, your D-dimer's negative, your Wells is negative, go home, you don't have a DVT, They were representing the following days because they still had the same problem with swollen legs. So really how you run your service is up to you, but I don't think an exclusion service will be beneficial. Okay, so I'm going to talk a little bit about these swollen legs, because we know in terms of rates of presentation, it's a lot of numbers you will see. Actually, when they have a positive DVT, it's quite easy to deal with, isn't it? We have very tried and tested treatments. We know what we're doing, but it's the ones that have the alternative diagnosis. Those are the ones that we, in terms of this first case presentation, those are the ones we're looking at. And what I would recommend you use is a kind of problem-based learning approach to how you deal with these patients. For those of you that haven't heard about problem-based learning, it was developed years ago for medical education, and it's just a system that gives us a kind of better understanding and knowledge of the thing we're looking at. But it's a very, in terms of learning, it's the participant who's actively involved in it. And when you're thinking about problem-based learning, we're dealing with the comprehension of the case and not the facts. And actually the methodology of problem-based learning, not just for VTE, it can actually be applied to all presenting complaints. And I'm going to give you an example of how we would do that for swollen legs. Okay, so patient comes in with swollen legs. Now, when you actually sit down and do problem-based learning, if you think about it system by system, there are probably hundreds of potential diagnoses you could get to. And what problem-based learning allows you to do is it gives you a bit of focus, and it gives you a systematic way to think about, the swollen leg. So if you think about cardiovascular things, well, it's usually pump failure that gives you the swollen leg, isn't it? So any kind of pump failure. We can often see a lot of edema with pericarditis, for example. We see a lot of edema with chronic venous stasis. What we actually see more commonly than DVT is superficial thrombophlebitis. So we've got to think of these alternative diagnoses. Lymphedema, very rarely you might see the odd cardiac myxoma, peripheral vascular disease. So even within the cardiovascular system, there's quite a number of potential diagnoses you can get to. Respiratory, well, we see things all the time like cor pulmonale, pulmonary hypertension, secondary pulmonary embolus, lung cancers, infections, all these kind of things can give edema and swelling. If we think about the kidneys, well, chronic kidney disease, nephrotic syndrome, infections, urological cancers, all these kind of things, again, can cause swelling of the leg or legs. Again, when you problem-based learning, you're thinking outside the box as well. So you're thinking of a lot of kind of neuromuscular things. Now, again, these are very, very rare, but for example, you might have a neuromuscular disorder that's left your patient immobile, and you get a bit of venous stasis from that. So again, problem-based learning allows you to think of all these alternative diagnoses. Within the GI and GU systems, liver disease, cancers, pregnancies. What we see quite commonly, particularly in women, is big pelvic masses, blocking the iliofemoral vein, giving a lot of leg swelling. Endocrine system, we have metabolic syndrome, which, with the talk you've just had, we know that in extremes of weight, you often get edematous legs as a result of that. Also things like thyroid disease, Cushing's disease, malnutrition, and more commonly, when you're thinking about problem-based learning, think about the musculoskeletal system. And these are very, very typical things I see. For example, the other day I got 2 litres of pus out of someone's knee who the GP had referred in as query DVT. But things like gout, Achilles injuries, bursitis, arthritis, fractures, we do tend to see the odd sarcomas now and again, particularly in young people, again, red flag. Baker cysts, super common. And then, of course, we get the odd case of a GP referral of query DVT that turns out to be Cauda equina. Dermatological conditions as well, we know gives a lot of dependent edema. So things like cellulitis, ulcers, infections, eczema, really any dermatological condition that affects the lower limbs will give you secondary edema. And then in the drug group, again, super common, amlodipine or nifedipine, it gives you a lot of dependent edema, non-steroidals, gabapentin, the pill, metformin, and IV drug use, and we're going to look at that as a separate case. So when you think about it, we know that only 9% of our referrals actually have a DVT or a PE, But look at all these, alternative diagnoses. So how do we arrive at this? How do we arrive at these diagnoses? Well, absolutely everything is in that history, isn't it? If we think of our previous slides there, we probably had about 100 alternative diagnoses just for a swollen leg. Everything is in the history. So let's getting back to good basic bedside medicine. Everything is in that history. Of course, bedside examination plays a small part in it, a really good thorough examination, and diagnostic tests will help. Now, if you think about our diagnostic test, well, we have two things we do at the start, don't we? We have the D-dimer and we have the Wells score. Now, we are now supposed to be a sort of clinical reasoning thinkers, aren't we? We're supposed to challenge everything and reason every diagnostic test we do. And even if we think about the D-dimer test, we know it's an extremely sensitive test. It's an 100% sensitive lab test. So if the D-dimer is positive, and 100% of times it will show up on that lab test. But is it a sensitive test? Sorry, is it a specific test? Because it's an 100% sensitive test, but it's only 37.5% specific. So actually, if we're thinking about clinical reasoning, its positive predictive value is only about 67%. So is it a useful test? Well, probably not. It's only useful when it's negative, but it's also a test not to be used in isolation, positive or negative, because we've got to look at our history, our bedside examination, and our Wells score as well. Also remember with the Wells score, there's a section in it that you've got to take off 2 points if you've got an alternative diagnosis. And when we look through those slides, when we do our problem-based learning and we look at those alternative diagnoses, actually probably most people you see, you will be able to take off that -2. Just remember as well, if you don't take off the -2 when there's an alternative diagnosis, it invalidates the score. So it's just something to think about. The next case I want to look at, particularly when we're thinking about the Scottish perspective, is the big elephant in the room in Scotland, and that's in our intravenous drug user group. Now, we know that, and it was quite widely publicised in the media last year, that in Scotland we have the most amount of drug deaths in Europe. And it's a really sad statistic, actually. And if you look at this slide here, what we can see is as each year goes on, the drug-related deaths, and these are just the drug-related deaths registered, but the drug-related death registered in Scotland has gone up year on year on year. And in 2020, that number was over 1,300. We know in Scotland, substance use or the harm from substance use is a major public health problem. Our patients come to harm both from ill health and early death, but we also know it's disproportionate, and it's disproportionate in the most vulnerable groups in our communities. And these are all statistics from Public Health Scotland and are kind of widely available on their website. But looking at the year 2019 to 2020, there were over 1,400 drug-related hospital stays. So it is a big burden on our health service. But the highest rate of the people who stayed in hospital, it was associated with opioids. And this is a group of patients we'll look at in this case study. Because we know in the heroin group, particularly in the injecting heroin subgroup, that the risk of VTE is super high. But it's not all bad news in Scotland. And as you can see from this slide here, that the heroin use year on year has actually gone down. The other sort of main drugs of misuse groups, so for example, diazepam, cannabis, have stayed fairly static. What we're seeing is an increase in cocaine and crack cocaine. And what we'll start to see in the coming years is an increase in the other groups like gabapentin and pregabalin. So we're seeing the heroin groups start to come down and down, which from a VTE point of view is good news, because if people aren't injecting, then the risk goes down and down. But what we are starting to see is other drugs of misuse starting to come up. But in terms of heroin, we can clearly see from the data slide here that the numbers are starting to come down. Okay, so when intravenous drug users present at your VTE services, well, they're so hard to deal with, aren't they? Hard to deal with in lots of ways because they're a population with an extremely chaotic life. So that means, for example, you can't really manage same-day ambulatory care, because can you guarantee that they'll come back to your clinics the next day, for example, for CT scans or for Doppler scans? Can you guarantee they'll be concordant with their medications? What we see in Scotland as well is that often there's quite a high street value in anticoagulation. So often they'll come in seeking anticoagulation to take home and sell on the street as well. So when we talk about chaotic lives, you know, and you'll know from your own experiences as well, they're a very challenging group to deal with. The other thing as well, that when they come into hospital, what you need to realise in this sort of chaotic group is that they must be at an extreme of their health to come into hospital, because we know they very, very rarely come in unless they have to. And we have to, again, use a problem-based learning to think about this client group, because often they'll have extremely swollen legs, they'll have a lot of problems with ulcers, venous stasis. But we need to start looking at the more kind of red flag things. And these are the kind of things we see really, really commonly. So we see things like abscesses, we see pseudoaneurysms. Only a couple of weeks ago, I had someone with an absolutely huge psoas abscess who was, you know, GP had phoned in as a query DVT. We see cellulitis really commonly and chronic venous insufficiency really commonly. So again, use that problem-based learning to try and identify the other bigger red flags for illness. But the other thing I'd encourage you to do as well is, because we don't often see these patients, and when we do, we probably don't often see them again. So we might, like I said, we might make arrangements to see them back at clinic or in your department the next day, and they often don't come. And what I would challenge you all to do is use this as an opportunity for intervention. And I don't just mean for working them through for query DVT, I mean for everything. This might be the one and only chance to have an opportunity. So, for example, to check bloodborne virus screening, to refer to your community addiction service, to encourage, you know, to challenge them on whether they go to safe injecting rooms or whether they do needle exchange programs, that type of thing. So it's very often your one and only chance to hopefully make a positive intervention in this group. And of course, the key thing you need to do all these things is consent, because if the patient doesn't consent to any of these things, then it's, again, can become very difficult. So what do? So we know it's an extremely challenging group. We know the risks of concordance. And if you're still injecting, we know the risk of treatment with anticoagulation is extremely risky, because if you bleed into an aneurysm, for example, then it's bad news. So it's super challenging, because there's no risk-free option in this group of patients. If you treat with anticoagulation, big risk of bleeding, and if you don't treat, then big risk of a recurrent clot and potential complications from that. So what we developed in the west of Scotland was a pathway that it's more for guidance as opposed to set in stone, because, you know, acute medicine is a specialty of risk. Whether it's VTE or all the other things we see, it is, you know, a specialty of risk, and there is no zero risk option with this group. So this is just for guidance as opposed to a clear set in stone pathway. And actually, the first thing we do is assess their suitability for outpatient management. And the things that we think about when we consider that is there any other pathology going on, i.e. do they have cellulitis or an abscess that might need incised and drained? So they obviously come in, they need IV antibiotics and a surgeon. We also think about secondary PE. So, you know, again, if we go through our problem-based learning, take a really good history, if they've got any suggestion of secondary pulmonary embolism, again, we wouldn't treat as an outpatient. And the other thing we think about when we're streaming these patients is, you know, their suitability for outpatient management, i.e. how chaotic is their life? Is there a high chance they'll not attend for their scan? And if that's the case, we would consider keeping them as inpatients. Again, whether the patient consents to that or not, it's a different story, but those are the kind of ones we would probably just keep in to make sure they got their scan the next day. And then this is a difficult bit about treatment. And what we think is the safest thing to do is, if they are still continuing to use IV drugs before the ultrasound scan, that we probably don't give them anticoagulation. The risk would be too high, particularly in the outpatient setting. So what you might do is give anticoagulation, send them home, never see them again, and you don't really know if they're safe in the community. So if they're still continuing to inject drugs, we don't give them anticoagulation. But then this is, again, on a case-to-case basis, and we always just say, you know, discuss with the consultant what their thoughts are. But if they're saying they're not still injecting drugs, then we do administer anticoagulation, and we administer it in the normal way, whatever is your on your own health board's guidance. So, for example, we would either use a low molecular weight heparin and fragment, or we would use apixaban. So you can still anticoagulate in the same way. And then we would arrange our outpatient ultrasound slot and review appointment as normal. We also would consider antibiotics if it was indicated, and it's strong worsening advice. So this is quite clear on the guidelines that, you know, you have to not only discuss the risk of anticoagulation with your patient, make sure it's documented in the notes that that discussion was had as well. I'm sorry, this slide's a bit wee if you can't really see it, but if they have a confirmed DVT on ultrasound, then we have to then reassess their suitability for outpatient management again. Did they turn up for their appointments? Did they turn up for their medications? So again, we're reassessing the suitability for outpatient anticoagulation. We have a clear exclusion policy. So for example, if you've got a significant coagulopathy or your platelets are below 75, then no, we don't anticoagulate. If they're likely to continue to inject or their lifestyle is so chaotic, then again, it's a difficult decision and it's case by case decision. I can't tell you there's a right and wrong answer to this, but we probably don't. The risk of bleeding would be greater than the risk of reclotting. So we, you know, and the people that are continuing to inject or have a super chaotic lifestyle, we don't tend to anticoagulate. And the other group as well, if someone's registered with a GP or someone's registered with community addictions, whatever, then they're probably a little less chaotic. But if you're not registered with any of these things, then how do you follow these patients up? It's just the risk is too high. So we tend to see these patients aren't suitable for anticoagulation. If you are suitable, then again, you just continue with the normal anticoagulation, but we have a number of choices. And that really is to think about the lowest risk for anticoagulation for this group, because while they may not be injecting now, who's to say, you know, you don't know in a couple of weeks, a couple of months' time, you can't predict what will happen in their lives in the future. So we tend to just stick to 6 weeks. We think this is the safest option in terms of bleeding, and at 6 weeks is probably enough to see them through that kind of prothrombotic period to stop recurrence. But you have to remember that that duration is off license, and that is just what in the west of Scotland, their kind of expert panel of haematologists and pharmacists think is the, you know, the kind of middle ground. But just to remind you, that is off license or off label, sorry. Again, we can offer alternatives. So for example, you know, in the talk you've just had, we've been looking at renal function, or you have an interacting drug. Well, there are alternatives to DOACs. You can think about low molecular weight heparins, etc. And what we normally do is supply a 3-week course. That's all. We've went with apixaban, and we normally prescribe a 3-week dose and then speak to the GP. It does say in the protocol, you know, be clear on the discharge letter, but we always tend to phone the GP just to make sure that they are clear on the plan and actually clear, you know, what they have to do as well. Again, if it's a more challenging case or more chaotic, what we tend to do is just ask them to come in every day to pick up the prescription. And if they do that for 5 or 7 days in a row, then we know that the concordance is likely to be greater. So there tends to be a bit more trust if you do something like that as well. But yeah, so we agree the plan with their primary care, or even if they're on methadone, for example, their substitution prescriber, we make it clear to them that, you know, that they're on anticoagulation as well. If there's no IV drug use for over a year, then we just put them on to standard 3 months of apixaban. So they have, you know, we make sure they're stable, non-chaotic life. And that's usually people who have community addictions or on a methadone program, and that we think are likely to comply with medication and monitoring. Again, we agree that plan with their primary care physician and with their substitution prescriber. So that's one of the kind of, you know, if we're thinking of the Scottish perspective, and I know we see it up and down the UK, but, you know, particularly in Scotland, there's no denying we have a big drug problem in Scotland. And in terms of VTE, I just really want you to remember that there is no zero risk option here in treatment or not treatment. The third case I thought we'd look at are the unprovoked VTEs and the persistent risk group VTEs. Now, the reason I think these are interesting cases to look at is because in same-day emergency care or ambulatory care, we give a diagnosis, we give treatment, and then what do we do with them after that? So we know that in the unprovoked group or the ongoing risk factor group, we know that their risk of VTE recurrence is high. And we know that if you're male, if you're aging, if you're had proximal DVT or you've got residual thrombus mass, there's a lot of ongoing risk for VTE recurrence. So what do we do in ambulatory care? Do we just say, you've had a clot, we send them home and never see them again? Because there's no clear system in primary care to review these patients again or to decide whether they need to have extension of their anticoagulation or even consideration for long-term anticoagulation. We know that the European Society of Cardiology gave us a kind of guide as to what your risk of recurrence is. So we know there's kind of low risk, intermediate risk, and high risk. We know the high risk groups are the people with active cancers or have had unprovoked recurrent VTEs in the past or have antiphospholipid, for example. We know they are high risk groups. So we should always consider treatment extension or lifelong treatment in this particular group as well. But we know there's the low risk people as well. So, if you've had, surgery and you've taken away that risk, you're unlikely to get another clot. We know that, sort of acute exacerbations or acute illnesses, you take away that risk, you've taken away the risk of a recurrent clot. But it's this group in the middle, and this is a group that interests me the most, because this is a group who have this either transient risk or persistent risk. So, for example, we looked at extremes of body weight there. So if you're, say, 100 kilos, 120 kilos, then you're unlikely to remove that risk, for years. We also know there's, for example, the inflammatory bowel disease group or the autoimmune disease group. So we're unlikely to remove that risk as well. So it's this group in the middle. It's this, the persistent risk group that interests me, because we give them a short course of treatment. We give them 3 to 6 months of treatment, depending on whether it's DVT or PE, and then we don't see them again. So we need to now start to think, well, if you've got ongoing risk, where is the responsibility for reviewing these patients again? Does the responsibility lie within primary care, or is it secondary care with us? So there's actually a number of ways you can now start to think about how you're going to deliver that, this next bit of care. What we tend to do is, again, it's all about patient selection. Because there isn't a robust system where I work in primary care to see these patients again, we bring them back to our own clinic, our own acute medicine clinic, 1 month off treatment, do a DASH score and assess the risk. And we assess the risk in terms of, was it provoked or unprovoked VTE? If it's provoked, is it a major or minor risk factor? Is it a transient or persistent risk factor that's left? Was it a first event or a recurrent event? Where was the thrombus? What was the burden of that thrombus? What were their bleeding risks during anticoagulation and other comorbidities? But the most important thing, actually, when we think about realistic medicine, is patient preference. We would often tell our patients, your risk of a recurrent event is this, your risk of bleeding is this. What would you like to do? Most people tend to prolong their treatment, but again, it's a case by case. And if you think about realistic medicine, put that, you can always put that choice back to the patient. But this is a big question, and this is where I think a lot of the conversation will come in. How do we deliver these VTE services? So COVID changed everything, didn't it? It changed the way we looked at our processes. It changed the way we deliver our services. We're all sitting on Zoom just now, and a lot of times our consultations are now over telephone or camera with our patients. We're very rarely bringing people back for face-to-face. So I think COVID has given us an opportunity to now think about, in terms of recurrent risk patients, how we deliver that aftercare. And I think your services shouldn't just be about, clot diagnosis. I think you need to start thinking about how your service will deliver this review. And again, that's a debate, whether it happens in primary care or secondary care. I don't know what the answer is. Some systems some warfarin clinics are now starting to diversify and start to offer these kind of services, do the DASH score, assess the risk, monitor, etc. I know a lot of community pharmacists as well do renal checks. If they're on long-term anticoagulation, they do renal checks every year. So Is the answer in primary care? I don't know. I think probably, but this is where the conversation lies. So thank you so much for your time.